Okay, it's 2 o'clock Central European Time. We're on time, and let me share with you the great happiness to finish the 2024 program of Yellow Webinars with Aleksander Krag. Aleksander, in addition to be a well-worn hepatologist, the director of the Department of Gastroenterology and Hepatology of Odense University, director of Center for Liver Research at the same university hospital, is also the current secretary of EASLD. And it's a quite busy guy. And let me tell you that his seminar is going to be the icing of the cake after a very successful year of the Yellow Webinars. So we are really grateful to Aleksander, who accepted our invitation. And the title of his seminar is going to be Alcohol and the New Nomenclature of Steatotic Liver Disease. Sort of some confusing arguments moving around literature nowadays. Aleksander, the mic is yours. Thank you very much.
Thank you very much, and good afternoon, everybody, and thank you for the kind invitation to join the Yellow Webinars. So I'll just share my slides here, and then we should see if we can get it going. So do you see my slides well now? Very good. So the point of departure is the new nomenclature, the new way of seeing steatotic liver disease as a spectrum. But I think also alcohol-related liver disease is becoming a new frontier in hepatology, or maybe an old frontier. It's still the leading cause of liver-related morbidity and mortality in most countries in Europe and beyond. Just move forward here. So these are my disclosures. So I have a full lecture here, so thank you very much for that, and I can unfold things a bit. So my outline would first to take the societal perspective, alcohol as a societal challenge. How big is it? How challenging is it? Why is it really important? And then how to see how do we see it? And then see how do we actually see the interaction of alcohol and metabolic dysfunction. That's the way we see it in a model world, and that has huge implications for clinics, but certainly also for drug development. Something about biomarkers and what I see as a current best practice. Let's look at the societal challenge. So liver disease is responsible for 2 million annual deaths around the world, 300,000 in Europe, and roughly half, a bit more of those, are actually attributed to alcohol. Alcohol do more than liver. I'll not focus that much on it today, but you know, alone alcohol is responsible for 800,000 deaths in Europe. So we should be holistic. I'll get back to that in our view. We look at the most recent EASLD Lancet Commission. I'll just make a pointer here. Here you can see all the countries, and here you can see the premature death due to liver disease and what part is associated with high body mass index, surrogate of obesity and alcohol consumption. You can see again, these are the two lead drivers of mortality in most European countries, and alcohol is the bigger one. And I'll come back to this, probably a part of underreporting. Most people don't report fully, even if it's a questionnaire, how much they drink, and this is the leading cause. And then there's the interesting thing when these things go together. What does that actually mean? Another, I think, very important factor for understanding and responding to alcohol-related liver disease is the societal burden in terms of working life years lost. And since alcohol is peaking there in around 50 years of age, alcohol-related liver disease is actually second leading cause of life years lost in Europe. That's a bit surprising to many. And that's because other lifestyle-associated factors, here it's something with smoking or obesity, they often emerge as more advanced ages. So lung cancer, it's plus 70, most people are retired by then. So the socioeconomic or the economic factors in society are less burdensome. And the same also with type 2 diabetes and cardiac. So that's important that this emerges early and therefore have consequences also for the society economic level. And who does it hit? So if you look at this graph here, you can see this is year of diagnosis of cirrhosis. And then you can go 10 years back, a nice study done by Peter Jepsen in Denmark based on the registries. And you could see what is the employment status. And here you can see the green is employment stage. If we go 10 years back, 60% are employed. If you go very close to diagnosis, 15% are employed. And again, you can see the different distribution. And if you compare that to controls, it's a completely different story. So that tells us that the socioeconomic factors are very important to target and to challenge this group of patients. And that's also what we integrated into understanding in the new Lancet Commission. This was just the appetizer to signal to this community that this was happening, but it will come out next year, and it's already very advanced. But if you look here this is trying to make a coordinated response to the burden of liver disease in Europe. We take the bottom here first. Currently, we are focusing very much on advanced stage disease. Our response is transplant, which is a magic thing for those that happen to it. But the burden, of course, cannot be managed by transplant. That's why the whole orientation in I think, hepatology as large is towards early detection, is towards prevention, screening potentially, and early treatment or secondary prevention. If we then look up here, see what is it actually that are driving liver diseases in this is a European context. It will look a bit different in other countries. European North America looks very much like this, that we have cardiometabolic risk factors, which is present in 98% of all with steatotic liver disease. Alcohol is an important bacteria, and virus is also there, but this can be overlapped. But we should not forget the structural determinants of health, the economic and social stability I just showed you, physical environment, but also health literacy and food security, things that drive these diseases. And what is the consequences for this? Because there's a significant stigma associated with disease, self-stigma, society stigma, doctor stigma. And that leads to, I think, is probably the explanation behind this. So this is the odds ratio of being diagnosed at advanced stage. You can see many other diseases, we are pretty good actually at finding them at a pre-cirrhotic stage, but in alcohol, it often 60–70% are found when they decompensate. And that's a difficult state because reversibility is less strong there. But let me jump on to what is alcohol-related liver disease then in 2024. Of course, for us clinicians, it's more or less the same, and yet we got a new framework that actually changes the way we see it. And I think it is a big step forward because it sort of opened our eyes to see more dynamics of what is actually this disease. How do we target it? And this can open the wide for biomarkers to diagnose, prognose, but also for new treatment and trials coming up. I'll also show you later. Sure, you're all familiar with this figure here. It's very well cited, this collaborative work between the liver societies in the world, EASLD and ALE, and now endorsed by more than 75 societies across the world. That we see steatotic liver disease as the overarching term, and then we have this spectrum over here. It's mainly driven by metabolic factors, and here mainly by alcohol, but actually a spectrum that sort of moves back and forth depending on how much alcohol patients consume. So that also means we move away from silo thinking, which is obviously very unhealthy. Biology is not a silo. Biology is dynamic. Behavior is not either or. It's dynamic. It's actually something that moves up and down. And that's why I think this framework is much more logic and looks closer to reality. If it's the final answer to how we should see this, probably not. We might need some tiny refinements in a few years, but this is definitely a step forward from what we already have. In this paper here, we try to describe this journey coming from the NAFLD way of seeing it that dates back in 1980. It was made by a pathologist who was surprised to see that people could get liver disease when they were not drinking at all, and then put more or less an arbitrary level of alcohol consumption here. And that's we're still stuck with. If it's correct, evidence-based, we can discuss that. But then the problem is it was not an affirmative diagnosis. And we all know that alcohol is such an important factor, and even small amounts of alcohol in the patients with type 2 diabetes or obesity are actually important. So that was also missing. And then there was a whole thing, it uses alcoholic and have a non-alcoholic. So it started to say the disease was not. So that disease was not optimal. Then there was a group that developed the MAFLD suggestions for a nomenclature presented in 2020. They did go to a positive diagnosis, to affirmative, included steatosis. It also included alcohol actually, but didn't have a specific category. So that part was definitely a step forward, but was, I think, not clear enough on this. And also included cardiometabolic risk factors, but said more are two of them, but also have CRP in, which can also be discussed. It was based on an expert panel, but wasn't really, it's just endorsed by societies across the world. And then there was the next one, this EASLD, which was then a global consensus that again maintained this 20-30 gram to have low levels, and then created this intermediary group, the mid-ALD group and ALD group. So we have these three groups. And I think that's very important. And then used the cardiometabolic risk factor definitions we know from cardiology and endocrinology. So actually we can build on that and we can talk to them and speak the same language, which is also an advantage. And then it was Delphi-driven. It was a consensus-driven process, an expert and consensus-driven, and evidence-based to a certain extent. But of course, if you define something for new, you don't have the evidence. So that's again how this works. And now evidence are being generated. I'll show you some of that, and then it's endorsed by all these societies. So that's how I think you should see it. But then what is the natural history of liver disease? We try to put it together in this figure. So one thing is what we call fibrosis, compensated and decompensated cirrhosis. This is a histological feature. We don't biopsy all. So we also say there's an asymptomatic and a symptomatic phase. And the problem is, of course, we want to catch people in the asymptomatic phase. If you look here to the time frame, okay, here the progression is slow. Here it's actually fast. Down here, the mortality is very high. So that's the whole framework. How do we actually move to the earlier stage where it's preventable? And that's why we try to, with this new framework, try to see, okay, how should we actually mentally, clinically, scientifically, and drug development-wise see the steatotic liver disease? So if we start down here to the left, we have a normal liver, what we call a shared trajectory here. So going here all the way from the normal liver down to transplant or death in the other side into steatosis. Then we can have drivers from up here that are metabolic drivers, what we call the metabolic pathway if you have no alcohol, or down here where you have alcohol, but where alcohol is the lead factor. And then you can go to alcohol-related hepatitis, and you can go to progressive fibrosis and up here. So that's the way we should see it. But one important thing I want you to notice also from this figure is that the arrows go both ways. So learning we've come to understand, I think at least in the last maybe 20 years, maybe less, is the reversibility, that even all the way up to decompensated cirrhosis are reversible, at least in some patients. The earlier stages, they are virtually all reversible. And that's good news, because then we can actually do something. Then it makes sense to diagnose, it makes sense to develop drugs that can work in this. So this is sort of the framework where you got the pathway up here, metabolic driven, shared pathway that are a combination of both, and then somewhere alcohol is more driven. So that can be a framework of trying to understand it. Then I just told you that this was not an evidence-based thing, and some would say it's a bit dangerous to go down the road without evidence, but that's the way it was. So me and some of my colleagues then tried to say, okay, can we, let's try to validate it. How does this play out in clinical practice? And that was interesting for us to see that actually it worked pretty well. So here you have time without hepatic decompensation in the different groups. And this is the prognosis. And you can see there's a clearly distinct prognosis if you had no steatotic liver disease, MASLD, mid-ALD, and ALD. So I think from a patient perspective and a clinical perspective, this is meaningful. If there's different prognosis in the different categories, it's clinically meaningful in my view. And we saw exactly the same pattern in regarding mortality. And again, that's what the patients ask us, isn't it? What's wrong with me? Is my liver sick? And the next thing is, am I going to die or not? Or is it going to get worse? And there it actually makes good sense to put people in the correct categories. But let's have a look at the epidemiology of alcohol and cardiometabolic risk factors. Is this a big thing? Is this something we should be concerned about? I think it is. But let me show you some of the data. If you just want the summary, then you can take a nap in the next 5 slides. But here in this paper, we made a seminar here in the Lancet. This was just published here a month ago. One of the first panel we tried to put, what is the global prevalence of these? And that's interesting to see globally. Some countries obviously more, but what are 40 to 50% are overweight, 16% obese. So this is plus 30 BMI. A lot are living with type 2 diabetes. This is equivalent to 500 million people. 50% consume alcohol. So what I see here is some kind of variety. Almost the same number live with obesity that consumes alcohol. 20% drink heavily at least once a month, and 16% engage in harmful alcohol consumption. That's a lot. And that's again the same number of patients living with obesity. So these risk factors at the global level are actually both more or less equivalent, and we're trying to understand them actually together and as driver of liver disease. This is just to support my statements there. So this is a number of current drinkers, and in most European and American countries and others, a lot of people drink, and they drink frequently. This is how many drink heavy episodic drinking, what we call binge drinking, where you drink more than 5 units at the time. Sometimes I call it that you do it within 2 hours, but still that is heavy drinking. And again, this type of drinking behavior will lead to steatosis, because when alcohol is metabolized, it will end up like triglycerides in the liver. So that's very frequent. On average, these roughly 25% engage in that. And this is how much alcohol that are drinking in globally. I can see my country, Denmark, has a proud record. We almost drink 12 liters, and that's several European and United States, I think it's 11 liters, and then there are countries that drink less. But the thing is that is more or less stable. Some countries go a little bit down, some countries it goes up. But alcohol is here to stay, and that comes at some health consequences. So if we look at the world map, we see what is actually driving liver disease. And you can see the red part is where alcohol is the lead driver, and that constitutes a lot of countries. And then the yellow is Hep C. I'm not sure this would be valid if we did it real time now, because many countries, including these yellow European countries, are doing a pretty good job of reducing the burden of Hep C, which we all know is a pleasure to treat now. So alcohol is and will be the leading cause of liver-related morbidity and mortality. And this is again to see, okay, how much of mortality is alcohol actually driving? So it's on average 5 to 6%, a bit more in some countries than the others. That means that this is actually a significant burden of the overall mortality. And that's back to that alcohol is believed to be responsible not just for the liver, but also for cardiovascular and cancers, for 3 million annual deaths. And the interesting thing is basically when it's alcohol, it's 100% preventable, at least in theory. Okay, this is again from WHO, the World Health Organization's report from this year, looking about prevalence of alcohol use disorder. So they used registries, they used ICD coding. You could see if we just take the top one here, that's Europe, it's actually going down, that's good. But still we have roughly 10-11% of people having alcohol use disorder, and the same in North America, and then we have lower in the rest of the part of the world. But yet the lowest is around 5%. And the sample here with alcohol dependence, roughly around 5%. So the alcohol consumption over the world is big, and there is a group that drinks a lot, and they are at decreased health risk. So that's what we are trying to understand here. And this is again the trends over time. Basically, what I want to show that if you go to the aggregated level, it's more or less stable. Let me jump. So this was trying to put the burden of alcohol. Then let's have a look at the burden of metabolic dysfunction. So metabolic dysfunction, that's then the cardiometabolic risk factors. So this is from the global burden of disease, with the risk factors that are driving morbidity and mortality from 1990 to 21. And the green ones are the cardiometabolic risk factors. You can see them here, and they are in top 10. These are really important. Alcohol is coming here in 1990 as 10, and then moved one up to 9, so it's still part of it. But of course, the cardiometabolic risk factors is mainly associated to cardiometabolic diseases, why this is numerically so important here. But interesting to see that alcohol is coming in just next. But we're trying to understand how these interact and why these are important together. This is the one on obesity. I could talk a lot because this is an interesting graph. Recent publication from the Lancet, again, 1990 to 22. 1990, they have a green. If you look at this heat map here versus this one over, this one does not have a green. This had a green. That was a time when the world was still, there were places in the world where underweight was more important than overweight. Now it's completely different and the other way around. And obesity is very frequent all over the world. Well, then look at how many of these patients with steatotic liver disease then have cardiometabolic risk factors. A study we published earlier this year, we look at a very well characterized group with more than 400 patients that had a liver biopsy, and we could characterize them into not steatotic liver disease, steatotic liver disease, MASLD, mid-ALD, and ALD. And then the color coding here, you can see the more red, the more cardiometabolic risk factors. And you can see that if we just chop here and say, okay, how many have 4 or more cardiometabolic risk factors, then you're metabolically quite unhealthy. That was about 45, close to 50%, and not that different in the group. Maybe a tiny bit lower in the ALD versus MASLD, but not so different. And another interesting finding was that in patients that only had alcohol but no cardiometabolic risk was a very small group. So 98.5% had at least one cardiometabolic risk factor. It makes good sense. We know that alcohol increases blood pressure. We know it changes triglyceride. We know it contains a lot of calories associated with overweight and obesity. So no big surprise, but in reality, don't stare blind on either alcohol or cardiometabolic risk factors because they are interrelated. This is just a sum up slide. Again, if you look at patients with steatotic liver disease, depending on what population you look at, a lot live with obesity, diabetes, dyslipidemia, hypertension, and have cardiovascular disease. And that is the integrated system we try to understand as physicians and as researchers to improve health. But let me again give you some data on what does it mean to have both of these, because that's important, because there's a synergy between the harmful effects. We've known that for quite a long time. This is an old study where they looked into the relative risk of cirrhosis, depending on if you had just high BMI, it was elevated, or had high alcohol, elevated. But the interesting thing, if you have both, it's not just 1 + 1 is 2, 1 + 1 is then 4 or 5. And that's the dark blue part here. That's what we call interaction. And that's why it's very important that we look out for patients that has more than one factor, because their risk of progression is different from those that does not have it. Then you can dig one level deeper. In here, they looked into the genetic variant PNPLA3. We've also known for more than a decade how that is associated with risk of steatotic liver disease, both where alcohol predominant and non-alcohol predominant. And what they did here, which was very nice, they looked into drinking, obesity, and if they were carriers PNPLA3. And then they could sort of add it up. Okay, could you then in the top, you have drinking, obesity, homozygous for PNPLA3. There was a massive increased risk here, 10-year rate of cirrhosis versus that. So that's again the same story of the interaction, just with another layer. And here's another study looking into polygenic risk scores and binge drinking. But again, the same way, heavy drinking, polygenic risk scores alone, diabetes alone, not that bad. But if you have all of them, the gray one here is the interaction. And that is what will be important when we go towards more personalized healthcare, understanding individual risk and start to use genetics in clinics, which I think we should, because genetics these days are not very expensive to get, and you just need them once in your life, and then you got them the rest of the time. Okay, let me then tell another story. So it's again, so which one is the more important one? That's difficult to say. But if you take a group of patients, we did here more than 300 patients with alcohol-related liver disease. And then you see among that group, we know they drink, we know they have alcohol-related liver disease. What is the most important factor for outcome? Yeah, that is the cardiometabolic risk factors. That is HOMA-IR, which is a reflection of insulin resistance. So in that group, adding that to the is associated with prognosis. If we then look from the other side, from a large group of patients with type 2 diabetes, you have 50,000 patients. And then they looked about where we can measure this or calculate this attributable risk of liver disease progression in these patients associated with alcohol. And more than 50% of the liver-related outcomes in these were attributable to alcohol. So meaning that in a diabetes population, alcohol would be the most important factors, and in the alcohol group, the factor that distinct in the individuals is associated with cardiometabolic risk factors. But let's see, how do we then put all this together, both of these knowledges of the alcohol and the cardiometabolic risk factors? And how does that actually play out in terms of frequency? So we know that MASLD is very frequent. We see all these population here is 32%, sometimes it's 38%, mid-ALD lower, alcohol around 1%, here down to 1%. That means the world look like this. The one to the left is the entire world. We have whatever, roughly 30% have steatosis in the liver because of cardiometabolic risk factors, and 3% have it for alcohol-driven reasons. My question here is then, what puzzles my mind when I put this together a while ago, how can we actually reconcile it? That alcohol is responsible for a small fraction, but I just told you that 90% drink alcohol, 10% have harmful alcohol in consumption, alcohol use disorder, 20% binge drink. So there's three ways to explain it. One is alcohol protect against steatosis, and that's biological not possible. I already told that with the breakdown, the triglycerides, so that alcohol just makes steatosis. That's a fact. Second thing is that the WHO data I told you are wrong. I think not. They're based on diagnosed codes. I think they're probably underestimates. So the third thing is actually the databases on alcohol in the cardiometabolic papers are underestimated. So I think there's a big underreporting of alcohol. And actually there are already some papers out here looking at. So this is the level of underreporting of alcohol in different studies. Was even here in the randomized clinical trials, and this is from the Maestro trial, the resmetirom trial, 10% have a PEth measure over 20. This is a register-based study from Sweden that looked into ICD coding, a basinal study here. So a big chunk of these are likely underestimated. So the question is, what does the world look like if I'm right? And it might look like, if we say that 25% are underreporting, then a third of steatotic liver disease is actually driven by alcohol. So that's a new way of seeing, instead of 3%, it's 30%. But the span is somewhere in between, that if it's the lowest risk of underreporting, then it's 20%, the highest risk, then it's more than 50%. So to me, that brings a new perspective on how we epidemiologically should see steatotic liver disease. And I think that has important implications. There will be differences in regions, etc., but it's probably more like that. And that could also probably help us explain this, what we call I'll just show you the next picture. We call it the steatotic liver disease burden paradox, that with the knowledge we have now, the data we have available, the prevalence of MASLD is very high, ALD very low. But we look to our clinics and we look to who dies. It's the other way around. And that's also what this shows here. This is cirrhosis from Germany. Alcohol here. The total up here, alcohol is here, and you can see it cuts here. And then you have NAFLD down here. That was the term that time. So whatever, 10, 15 times lower. So there's something that does not add up we need to look into. But I think that's probably to some extent or large extent associated to underreporting of alcohol. Another thing which I think we should also, when we try to understand this in a model world and the new nomenclature, which is doesn't really capture, is that we know that alcohol drinking is not stable over time. It actually changes. So this is a recent study from Gastro where they looked into the one of the databases there from the VA system and could show that 35% actually after 7 months changed consumption. Okay, what does that mean? And why is that? We already told you that these things should not be seen into isolation because these things affect each other. So these factors are interrelated, but they're also affected by a lot of factors in people's lives. So meaning that there's probably some dynamics, and we try to understand that in detail a little bit more. And so we had 1,000 patients here. I'll just push this forward to come to the conclusion. So we had 1,000 patients, a bit more, that we then investigated with 2 years in between, and then just apply the criteria for steatotic liver disease and see how they moved around. And you can see here, some moved from not having steatotic liver disease, something moved from EASLD, most out, mid-ALD and ALD also changed a lot. And what was a surprise to us was that the change in these were actually quite significant, and 2/3 of those where alcohol was driven actually changed category, but also those in MASLD. So that means from, I think, a trial perspective, but certainly also a clinical perspective, that once you have a diagnosis of MASLD or mid-ALD, ALD, this is not a definitive diagnosis. That can very easily change in 6 months, 12 months, and we need to reassess. So in our data set, which was an observational study, it was 38%. Might be even more in clinical practice. So I think that's one takeaway. We should definitely reassess this down the road. Let me talk a little bit about biomarkers. We got a ton of good biomarkers for this, for diagnosis, prognosis, and also now for monitoring. Again, what is the challenge? I already showed you this. This is about late diagnosis. So we want to go to early diagnosis. We suggest to go with FIB4, and that's in the guideline. But FIB4 is not optimal. This is a low study in a low prevalence from the liver screen cohort we did a few years ago. And the problem is if you apply 1.3 and then use liver stiffness as a reference standard, then all these are false positives. And that's the problem. And these would be false negatives. And that's again the burden that FIB4 is actually a good and cheap and easy accessible tool, but is associated with false negative positives and probably make us see too many patients. So here is if you change the cutoff, then you just change the paradigm with less false positives and more false negatives. So what we did was to see, okay, ELF test. I don't know how many of you are using ELF test. We're using this and tried to have this pathway implemented here and say, okay, in 3,300 people, some from general population, some from with alcohol, and some with it was an FLD at that time. How would it work if we did FIB4 only? Yeah, there you can see only 36% were correctly classified. And around 30% were false positive. If we then did FIB4 and ELF, the correctly classified increased to 88%, meaning that the number you needed to see that did not have any disease was much lower. So that's, I think, the kind of thinking we need to have kind of reflexing to reduce the false positive rate. And this is the way we put together. I don't think I want to walk you into detail, just suggest you read the seminar there where we see which patients should you look into, cardiometabolic risk factor, alcohol, steatosis. Then you go with the FIB4, but you need confirmatory test, transient elastography or ELF test. And then we need a lot of the patients to go back in primary care and be reassessed some years later. That's the journey. The next thing the patient asks us is then the prognosis. Am I going to die? Is it going to get worse? So this is the prognostic performance of biopsy versus transient elastography, FibroScan, and ELF test. And you can see they actually separate very nicely here with the simple 10, 15 cutoff from Baveno, or 9.8 and 10.5. So meaning they are, for prognostic purposes, the same, and you also don't need a liver biopsy for diagnosis, for prognosis, because these are just as good. And to the right here, these are time-dependent ROC curves, meaning that this is stable over time. So you can actually trust it also to predict something years down the road. A final thing here about biomarkers is the biomarkers around what does change over time mean. So it's a big cohort here we did, and could see that if you had not had CACLD TE below 10, the risk of decompensation was low. If it was above 10, it was higher. So that's the group we should concentrate about. And then there are different dynamics if it increased or decreased. And again, you can see the curves here. It means actually, what does it mean when we reassess 1 year down the road? So we should develop some guidance how to use that. A little bit about current best practice. I think it's important we call it alcohol-related liver disease. We don't call alcoholism anymore. There's no alcohol. It's a person with alcohol use disorder. So we use person-first language. That's about destigmatizing. So please consider the use of this. This is a joint statement from all the liver societies in the world that all endorse this. Then using alcohol biomarkers. How do we assess alcohol? Of course, we need a medical history, but I just told you about the underreporting. We all use these GGT, MCV, etc., and they give us a hint, but they're not very accurate. Then there's the audit score. I know most people don't use it. It's been recommended for 40 years by WHO. I'll urge you to use it. If nothing else, then the audit C, which is an easy use one. I'll just show it to you, but also the PEth, which is a biomarker to suggest, or you can link together with your medical history to suggest current alcohol consumption. Yeah, just here, I have 2 studies here just to say what is the consequences of screening or finding patients with damage to the liver. One of our patients suggesting that if you find damage to the liver, we could track that 6 months or even 2 years down the road, they will improve their behavior. So knowledge about liver, specific knowledge about liver damage, improve behavior. And this is another study from Spain that essentially show exactly the same. So there's actually something gained, even though we don't have liver-specific treatments yet. This is the relapse prevention medications. Disulfiram should not be used. Naltrexone and encamprosate can and I think should be used. What I suggest you do if you're not into all kinds of therapy, we can all screen for alcohol, we can all make a brief intervention or refer them to treatment. So that's this framework, which I think is important because it's such an important and modifiable factor. So trying to put it all together here, this is the framework in the steatotic liver disease and the nomenclature. And then we have the different drivers. I talked about genetics, here about socioeconomic factors, cardiometabolic risk factors, and alcohol. And then we can put them in this framework and see what is your risk of liver disease. And it's clearly that already show you, the more alcohol you come, the more aggressive it is, and the less fibrosis you have here with the T also shows you the outcome there, the less aggressive it is. But also mean that down here, your risk of having a cardiovascular event is 10 times higher than a liver-related event. Whereas if you come up here, the liver-related risk is 10 times higher than a cardiovascular event. So that's an important thing for the clinical prioritization, and also that actually we do our stuff. So a practical approach, again, same here. We have all these things with different risk factors. We suspect this. Okay, do they have the cardiometabolic risk factors? Calculate FIB4. If it's low, keep them in primary care, understand the alcohol, and put them down here. And then we manage the cardiometabolic risk factors. We can easily do that. It's easy to treat all these today, also as hepatologists. They don't need to go to an endocrinologist. Alcohol relapse prevention, management, and then the secondary testing. Don't need a liver biopsy, do an ELF, do a TE on top of this, then it's actually very accurate. A little bit about the next frontier. I'll just use 2 more minutes because I'll just wanna emphasize that great things are coming and it is changing now. Yeah, this is sort of the framework of what we can treat. We know that alcohol is a lead driver. Anything that can reduce alcohol would be good. I hope for convince you cardiometabolic risk factors are important, and fibrosis is certainly important. and the vascular component in more advanced stage is also important. So this is a kind of a framework, I think, from all the different things you can do, and there are already phase 2 trials. I'll just show you them going on. 2 of them targeting some of these, and there's a lot of things happening, different companies considering how to approach this with the drugs that seems now to work very well in steatotic liver disease, or at least the EASLD MASH component. And here again, what is the framework? I'll show you just one study around genetic drivers, how GSK actually is doing a study there, and something here about the MASH and the fibrosis part, where Novo Nordisk is also moving forward with a drug. And again, targeting different parts of the natural history of disease. So far it's here, but soon there'll probably also be studies doing at the cirrhosis level. So what has led them to do that? There are some interesting data. This is just observational data, but semaglutide, that's a GLP-1 antagonist, and tirzepatide is a GLP-1 GIP agonist. That was associated when you have these large databases of these people drinking this, and the same also here with sema, they could see that they reduced their drinking and there were less people actually having an AUD diagnosis. So it tells us that, which is already known, that the drugs are working in the brain, but does not only affect eating behavior, but probably also drinking behavior. And that's again a complex. We're trying to map what does GLP-1 actually do. But if we then zoom that into a liver context, let's put it here to the right, GLP-1s, it takes obesity, we know that, treats type 2 diabetes, but probably also reduce alcohol drinking. So theoretically, that should be a very good target for alcohol-related liver disease. And that's actually what's happening now. This study has already recruited, I think, 60, 70 patients around the world. It's a phase 2 trial looking into semaglutide, cagrilintide, and this one is FGF21 analog. So this is great news. For the first time in history, we have trials, company-driven trials in this spectrum. And same here with GSK moving with their drug. That's again an antisense RNA for HSD 13B17. So a genetic silencer, since genetics is a driver. So also started to recruit, and both of them are registered in clinical trials. That's why I got this from. Otherwise, I just want to invite you all to EASLD Summit in Estoril in Portugal in January 23rd to 25th, where we will discuss all these things. There's a huge opportunity to network. We also have an ENCON conference about mid-ALD and ALD, and a consensus meeting about patients' trajectory. And if nothing else, then I hope to see you all in Amsterdam for the EASL Congress. We just had abstract deadline. I hope you send a lot of great stuff we can look at. And then if you don't already have EASL's guideline app, there you have, it's free, it's available. You can just download it and use it wherever you want, have your fellows using it, then please do it. We will just be happy to see it. Otherwise, thank you very much. This is my research group in Odense, and thank you for your attention.
Well, thank you very much, Aleksander, for the excellent talk and very stimulating presentation.